Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about cervical cancer with Dr. Mitchell Clark. Dr. Clark is an assistant professor of obstetrics, gynecology, and reproductive sciences at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Mitchell, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Absolutely. I'm, originally from Canada. I've been here at Yale now for 4 years. Prior to that, at the University of Toronto, where a lot of my research and clinical activity was around cervical cancer prevention, awareness, and obviously treatment of those diagnosed with the disease. Here at Yale, I'm a gynecologic oncologist and part of a really robust multidisciplinary team caring for women with gynecologic cancers, including cervical cancer.
So let's talk a little bit more about cervical cancer. Can you kind of paint us a broad overview of what exactly is the disease? How common is it? What's the mortality from it? I feel like a lot of us talk about cervical cancer, but we might not know the real details.
Absolutely. We're very fortunate in this country to have seen a dramatic decrease in the rates of cervical cancer, both in incidence and mortality. And a lot of that has to do with our robust screening program. So many women are aware of the pap smear, something that they talk very often with their gynecologists with. And the design around that is to prevent these cancers and to detect them before they even have a chance to develop. And so women will meet with their gynecologist, have a pap smear performed at a certain interval of time. And we try to detect these, like I said, before we even develop into a cancer. Because of that, we've seen a real decrease in the rates of this disease. However, we do still continue to see patients present to the clinic, often those who are not up to date with their screening, not up to date with the pap smear, who have unfortunately gone on to develop a cervical cancer. Oftentimes, though, these are still diagnosed at early stage because unlike many other gynecologic cancers, they often have a symptom. And for many women, that can be bleeding that is either irregular or out of sync with their menses, or bleeding in the postmenopausal period when women have ceased having their menstrual period. Because of this, women present early, where treatment options continue to be very favorable. And for most women, they will experience a good outcome from their cancer care, meaning that we're able to treat these with curative, definitive intent. However, of course, we will see and care for women who present with more advanced stage disease, but it's never been there have never been as many options now as there have been in the past to care for those women who unfortunately do come with advanced disease.
So let's talk a little bit more about, how we can detect cervical cancer early. Can you talk a little bit more about some of the guidelines in terms of screening?
Absolutely. We're very fortunate that this is one cancer where there is robust data to support the use of screening. Unlike other cancers like ovarian or uterine, where we don't have that data, the pap smear has really been effective at detecting pre-invasive disease, or changes in the cells of the cervix before they develop into a cancer. One of the most important discoveries has been the association of the HPV virus in its development and role in cervical cancer. And so beginning all the way back in adolescence, now we know it's important to offer vaccination to both boys and girls aged 9 to 11 to help prevent HPV infection and eliminate or dramatically reduce that risk of developing down the road. And so that data is very strong and supported by a number of different medical groups, including pediatrics. For those women who then either do or do not receive the vaccine, the guidelines for screening with the pap smear are still the same at this time. That may change down the road. But for now, we've come up with a combination test where we screen for both the HPV virus in the cells and the presence of any microscopic changes when our cytopathologists look under the microscope. And if women have negative results from both the HPV and the cells, they're actually eligible to be screened every 5 years. And for a lot of patients and for women, that has been a big change from what used to be an annual screening. But we know that the association of a negative HPV test with that screening confers a strong degree of protection over the course course of the next 5 years. And so women can feel reassured that they have a very low likelihood of going on to develop a precancer or cancer of the cervix in the subsequent 5 years. In terms of detection, though, and moving beyond screening, patients need to present to the gynecologist in the interim if they feel that they're developing any of those symptoms I talked about earlier.
And so, can you talk a little bit more about HPV vaccinations? I mean, it seems like we talk a lot about HPV in the association with cervical cancer, but some people might still be unaware about HPV vaccination, who should get it, when they should get it. And I understand that now the age guidelines for HPV vaccination have expanded. Can you talk a little bit more about that?
Absolutely. This is one of my favorite topics because I think it's a unique example of a vaccine that can be thought of as a cancer prevention strategy. I think when this first came out, in the early 2000s, there was a lot of reluctance around providing a vaccine that was associated with a sexually transmitted infection. However, we've seen just a dramatic reduction in HPV-associated cancers in patients who use this vaccine early on. And so the ideal time to offer vaccination is really in that adolescent period prior to first exposure to HPV. And so we typically say between the ages of 9 to 11. And I would strongly encourage women, men, parents, grandparents to have a very frank conversation with the pediatricians about ensuring that the HPV vaccine is included in the vaccine series for girls and boys. We know from some internal data in the state of Connecticut that the other vaccines recommended at 9 to 11 have an uptake rate over 90%, but completion of the HPV vaccine series in our state remains very low at around 50 to 60%. And there's really no reason for this other than some misinformation and reluctance on providers and sometimes parents in seeing the benefit to the vaccine. Although I don't treat head and neck cancer, we are seeing a really robust set of studies coming out demonstrating the association of HPV with cancers of the head and neck, and just another reason to reinforce to parents and to children who are taking the vaccine that we should really look at this as a cancer prevention strategy as opposed to something that is associated with an infection that's acquired through sexual activity.
Yeah, the reluctance on people to take this vaccine, I think is really concerning, and we've seen this not only in our own state, as you mentioned, but even globally, and and I think part of it is that parents may say, my child is not going to engage in premarital sexual activity, and so why should I vaccinate them between the ages of 9 and 11? Can you talk a little bit more about that?
Absolutely. It's parents and it's also providers. We've done a lot of work internally here in the state of Connecticut. I work with the Department of Health on this in educating both our pediatrics colleagues around ways to bring up these discussions with parents, because a lot of people still feel uncomfortable for some reason or another addressing a sexually related topic in a patient of that age. But the data really speaks for itself, and I think changing the narrative, like I said, to reinforcing that this is to prevent a cancer far down the road from 9 to 11. We're not looking to provide some sort of assurance to adolescents that having unprotected sex is safe because they're vaccinated. But really what we are looking at is the long game here, which is to prevent a cancer, a multitude of cancers, actually, not just cervical cancer, that could be really life-limiting, and looking at the sort of long-term investment of this very safe vaccine that has now been around for over a decade.
Yeah. If somebody is listening to this and they think, okay, I get it, but my child is now beyond the 9 to 11, and maybe they're in their late teens, maybe even their early 20s, can they still get the vaccine?
Absolutely. We've got a great, data set and clinical trials showing effectiveness in what we're calling the catch-up cohort. So those are a group of people who did not have the opportunity or maybe chose not to take the vaccine in the earlier years when it's initially recommended. But we do still see statistically significant benefits in a reduction of HPV-associated illnesses and cancers in those people taking the vaccine really up until their mid-20s. There is some new data to say that up until the sort of early 40s, there may be benefit, but it's quite individualized. And the recommendation is for people to discuss with their provider to see if maybe they would be a good candidate. But if we're looking at the cost benefit here or the risk benefit analysis, this vaccine is very safe. We don't see any major safety signals. This has been around for a long time. And if you can confer any reduction in risk, I think it's a really worthwhile conversation for both these, teens and 20-year-olds and these, middle life folk as well to have with their doctors.
Is the vaccine covered by most health plans?
Yes, most health plans do cover this because it is recommended by both the CDC and many major organizations who make our sort of national guidelines around vaccination. And in the state of Connecticut, for certain age groups, is covered as well. So these are things that you should definitely bring up with your pediatrician. And now we actually have a number of pharmacists and pharmacies that carry the vaccine and do not necessarily require the prescription of an MD. And so I think you certainly have that conversation with your trusted healthcare provider. And for those healthcare providers out there listening, I cannot reinforce enough the importance of your strong recommendation to parents and kids. We know that's the number one reason or that is associated with vaccine uptake is recommendation because you have that strong therapeutic relationship with your patients and their families. And to either seek this through the clinic that you get care in or to seek out a local pharmacy who has it in stock.
Is the vaccine given in one shot or is it multiple shots that you require to get immunity?
Great question. So it is designed to be a multi-shot regimen, depending on the age, whether it will be 2 or 3. Although, we have seen some data coming out of countries that are lower middle income where access to a repeated series is not reasonable or feasible. And there has been some very exciting results showing strong immunogenicity, even if you just get one shot. Obviously, we recommend patients get all 2 or all 3, depending on their age. But at least just getting the one seems to confer some protection. And that is long lasting, at least.
Can you clarify who gets 2 shots and who gets 3 shots? You mentioned that had something to do with age.
Yeah, so in the younger 9 to 11 population, the 2 is fine. Those of us in the catch-up cohort who would be getting it in the early 20s would be the 3 shot.
Okay. So let's suppose you have a child who has gotten vaccinated. Do they still need pap smears and HPV tests? And if so, when should those start?
That's a great question. For right now, we do not have any different guidelines for people who are vaccinated or unvaccinated. And the pap smears usually start somewhere between 21 to 25, and we defer the HPV testing till around 30, just because we know this virus is so prevalent in the community. And it takes many, many years for those cell changes to happen. So it can be a little complicated, but we have tried to make it as clear as possible for the family docs and GYNs in the community.
Perfect. Well, we need to take a short break for a medical minute. Please stay tuned to learn more about the care of patients with cervical cancer in honor of Cervical Cancer Awareness Month with my guest, Dr. Mitchell Clark.
Funding for Yale Cancer Answers comes from Smilo Cancer Hospital, where the lung cancer screening program provides screening to those at risk for lung cancer and individualized state-of-the-art evaluation of lung nodules. To learn more, visit smilocancerhospital.org. Breast cancer is one of the most common cancers in women. In Connecticut alone, approximately 3,500 women will be diagnosed with breast cancer this year. But there is hope thanks to earlier detection, non-invasive treatments, and the development of novel therapies to fight breast cancer. Women should schedule a baseline mammogram beginning at age 40 or earlier if they have risk factors associated with the disease. With screening, early detection, and a healthy lifestyle, breast cancer can be defeated. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and its Milo Cancer Hospital, to make innovative new treatments available to patients. Digital breast tomosynthesis, or 3D mammography, is also transforming breast cancer screening by significantly reducing unnecessary procedures while picking up more cancers. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Mitchell Clark. We're discussing the care of patients with cervical cancer. Now, before the break, we talked a lot about screening and prevention with HPV tests and pap smears and the very important HPV vaccine. But Mitchell, now I want to pivot a little bit into actually patients who are found to have cervical cancer. So, can you talk a little bit more about how cervical cancer is diagnosed, and how is that diagnosis made, whether on a pap smear or symptomatically?
Yeah. In general, we tend to detect these symptomatically because the pap smear is really designed to detect precancerous changes where an intervention can be undertaken to prevent development into cancer. And so patients will often have some type of bleeding symptom or some pelvic discomfort or pain, but in general, there will be some bleeding either between the periods or in the postmenopausal period, which prompts an evaluation by the gynecologist. When patients go to the office, they can expect that their gynecologist will offer a pelvic exam with a speculum to visualize the cervix in order to see whether or not there's any obvious abnormality suggestive of a cancer. Very often a biopsy will be undertaken at that point, which can usually be accomplished in the office, and that pathology and that result will help us better understand if those bleeding symptoms were related to a cervical cancer or not. And generally, at that point, whether based on the suspicion of the exam or whether the gynecologist would like to wait for the results of the pathology, they'll then refer that patient on to someone like myself or our team within the GYN group at Smilo in order to better understand the stage and treatment options for that patient.
How are patients staged? I mean, is this a series of imaging tests?
So exactly. So we stage these patients clinically, meaning we don't necessarily need to perform an operation in order to understand the stage. Historically, we would do exam under anesthesia with cysto and proctoscopy, but now we have really high quality imaging options. And we partner with our radiology colleagues to generally perform an MRI and a PET scan. The MRI is important to better understand the size and local features, local meaning, within the cervix of the tumor. And then the PET scan helps us ensure or detect any signs of metastatic disease outside of the primary tumor within the cervix. Once we have all of that information, we sit down as a multidisciplinary group and review those results, and then we can better understand which options it would be best for each individual patient.
Kind of take us through the options. What's on the table when it comes to treatment of cervical cancer?
A lot of this depends on, each individual patient, their age, and what their goals are. And so, we do unfortunately see some of these cancers occurring in women of reproductive age, perhaps those who have either not had an opportunity to carry a child, if that's within their family plan, or whether they're hoping to have more children down the road, but were faced with this diagnosis. So the first thing to understand is, does this patient have an interest in preserving her fertility options? We do know that for certain cancer stages or sizes of the tumor and in certain patients, a fertility-sparing approach is very reasonable and seems to have the same long-term oncologic outcomes, which is important. Obviously, that pregnancy would be considered high risk down the road, and there may be some issues in getting pregnant. But we've got many years worth of data now to show that in certain women, those options are reasonable and they do not have to compromise their oncology outcomes just for fertility. So it's been a very exciting advance in the field. For those women who are not interested in preserving their fertility or may not have that option based on the results of those tests that we talked about, we then have to decide, is this a woman who would be best served with surgery, meaning radical hysterectomy to remove the uterus, cervix, and tumor? Or do we think that this cancer would be best controlled with a combination of chemotherapy and radiation? And a lot of that depends on the size of the tumor, some of the information we get from the pathology, and our exam in the office.
And so for women who do want to preserve their fertility, clearly the radical hysterectomy is not a viable option. So what does their treatment algorithm kind of look like?
Right. So we do what is called a radical trachelectomy, which is a procedure to remove the cervix and the tissue surrounding the cervix. We also sample some lymph nodes at the same time to make sure that that cancer had not spread. What we do then after the cervix has been removed is reconstruct the uterus to the top of the vagina and place a device there called a cerclage, which helps prevent any dilation of the lower portion of the uterus during the pregnancy. It appears that this is a safe option for women who want to choose this approach. But as you can imagine, there will be some challenges with the with the pregnancy, and will need to be closely monitored by a high-risk team. But it appears that this surgery can be performed safely from a vaginal, laparoscopic, or even a traditional open laparotomy approach. And patients tend to do well in the long term.
Is this a longer or more complicated procedure than the radical hysterectomy?
Yeah, it can be a little bit longer and more complex. And that's why we certainly encourage patients to see a group or a team with expertise in this procedure. But for those who do undergo the surgery, they appear to have comparable oncologic outcomes and have gone on to carry children down the road, which is always exciting to see those pictures in the office when patients come back to see us and follow up.
Yeah, I'm sure. For the patients who, for whom fertility is not a major concern, you mentioned that there were two options. One was the radical hysterectomy, and the other was chemotherapy and radiation. Are those two equivalent oncologically?
That's a great point, and I bring that up with my patients when I talk to them because they do appear equivalent. And what we are trying to do is identify patients who would not necessarily require adjuvant treatment, meaning if someone is going to have surgery, we want to ensure that then after the surgery, there's no indication to give radiation after, because we know the toxicity and side effects are worse if patients need a surgery, and then we find out they need radiation in addition to that. So we try to pre-select patients to either need one or the other. For some reason, patients often perceive radiation or chemotherapy as maybe not curative, or I'm just trying to palliate this cancer. That is really not the case in cancer of the cervix, and we treat with a curative intent to make these cancers go away long term. So I try to help patients understand that we want to select an individualized treatment plan that is best suited for their individual scenario. And if that plan is radiation and chemotherapy, they should not feel that they're somehow being, put into a category that will not have the same outcomes as a patient undergoing a surgical approach.
So if they're equivalent, why would anybody do the radical surgery?
Yeah, for the smaller tumors, the radical surgery is, they have one operation. There tends to be a little bit less in terms of toxicity to the other pelvic structures, because radiation can have some side effects on the bowel, the bladder. Patients may experience some long-term issues in terms of diarrhea or constipation or bladder irritation. So in terms of toxicity, there certainly can be more toxicity with the radiation approach. But when looking at the long-term oncologic outcomes, they appear equivalent for certain stages of this cancer. Obviously, if we find on the PET scan that the cancer is spread outside of the pelvic area, then neither surgery or radiation are necessarily indicated, and we often choose a combination of chemotherapy and some of these newer agents like immunotherapy, which many patients are asking about and has been very sort of present in the media. And we're very excited to see that a lot of these immunotherapies and new drug developments are showing promise in cancer of the cervix as well.
So I want to get to the drugs in a minute, but just to finish up the conversation with regards to fertility preservation and the different options, for women who do want to preserve their fertility, is chemotherapy and radiation therapy an option if they choose to, for example, harvest their eggs or ovarian tissue prior to the chemotherapy and radiation? and that way they could avoid the more complicated surgery?
Absolutely. The retrieval of the eggs is certainly possible, and we have a wonderful group of reproductive endocrinologists that we work closely with who get patients in quickly to stimulate an ovarian cycle and retrieve those eggs. Now, if patients go on to receive the radiation and chemotherapy after the egg retrieval, the uterus will unfortunately not be able to function in the capacity to carry a pregnancy, but patients would have the option to use those harvested eggs with a gestational carrier or surrogate to carry a child that is genetically theirs. But unfortunately, the radiation does do damage to the uterine structures in terms of its ability to carry a pregnancy down the road.
Mm. Okay, so moving on to the patients who have metastatic cancer for whom chemotherapy or immunotherapy are indicated. Can you, first of all, tell us a little bit about how many patients or what proportion of patients with cervical cancer present with metastatic disease versus non-metastatic, and what's their prognosis like?
Yes, fortunately, we do not see a high number of patients. We're probably talking in the order of 5 to 10% who are presenting with metastatic disease when they first show up to the clinic. And this is likely due to our excellent screening and patients being aware of the symptoms to get care to detect disease in its earliest stage. But when these patients do show up, for years we did not have much in terms of options to offer them. Cytotoxic chemotherapy was really all that we had, and prognosis was not great for those patients. We're very excited to see the rapid expansion of drug development in the cervical cancer space, even over the last 3 to 4 years, where we have seen a number of new approvals and really ongoing interest and excitement in additional clinical trials that will hopefully see these drugs brought into the ovarian cancer space to help more women.
Yeah. So can you talk a little bit about some of the ongoing clinical trials and research that you're most excited about?
Yeah, absolutely. Like all cancers, we often see the new drugs developed for patients, later in their cancer journey, and it takes some time for those medications to trickle into the earlier phase of cancer treatment. And so use of immunotherapy in the earlier elements, so meaning not waiting for recurrence, or maybe in patients who have a tumor that is perhaps too big for fertility sparing, but maybe we can use an immunotherapy to shrink that down and then offer patients a fertility sparing option, I think would be very exciting, because with immunotherapy, we really see a difference in the side effect profile for patients as well. So it's not just about the long-term cancer outcomes, but how patients feel, their quality of life, and their experience during their cancer care. And immunotherapy seems to be offering patients a different and somewhat improved side effect profile when we compare it to some of the older chemotherapies. Other than that, we're excited to see some updated cervical surgery trials that have been presented in conference format to suggest that maybe for certain women, the radical surgery is not necessary anymore, and we can do a smaller, less invasive hysterectomy, but confer a similar long-term outcome for those women. And that would be a real game changer in the surgical treatment of this cancer. So we look forward to that publication coming out soon.
Dr. Mitchell Clark is an assistant professor of obstetrics, gynecology, and reproductive sciences at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.